Welcome back to Revenue RX, the podcast at the intersection of pharmacy and finance. I'm your host, Lubna Mazen. Today's topic is one I get asked about constantly, usually by pharmacy directors or finance leaders who just realized their organization doesn't actually have anyone whose job it is to own the pharmacy revenue cycle end to end. Coincidentally, as I'm recording this episode, today marks the 5-year anniversary since I was given the opportunity to build my first pharmacy revenue cycle team. Looking back, I made plenty of mistakes, learned a lot along the way, and that's really where many of these ideas came from. So today I want to walk through how to actually build that team, what functions it needs to cover, what roles typically fit in those functions, how to sequence the build as you grow, and where this team should sit on the org chart. Most hospital revenue cycle departments are staffed by people with a finance or health information management background. That works for a huge share of hospital billing. It doesn't fully work for pharmacy. Pharmacy revenue cycle sits at the intersection of clinical knowledge and financial processes. Understanding why a denial code came back on a biosimilar claim requires knowing something about the drug itself, how it's dosed, how it's billed, and what payer coverage policies actually say. A finance background alone doesn't get you there. Neither does a clinical background alone. The strongest pharmacy revenue cycle teams are hybrid by design, not by accident. You need people who could read clinical notes and people who could read a remittance file. And increasingly, you need people who can do both. Before you hire a single person, you need to map out the functions. A mature pharmacy revenue cycle program covers roughly these areas: revenue integrity, charge description master maintenance, charge capture validation, charge testing, coding accuracy, benefits investigation, authorization for high cost and specialty drugs, escalation management for urgent starts, working denials queues, appeals, root cause analyses, payer trend tracking, reimbursement analysis, drug spend forecasting, margin analysis by site of care and by drug, wholesaler relationships, 340B program compliance, group purchasing organization contract management, and ambulatory and infusion center operations. This is where the applicable oversight of revenue cycle touchpoints is specific to outpatient infusion and specialty pharmacy sites. Not every organization needs a dedicated person for each of these on a day-to-day basis or on day one. What matters is that every function has an owner, even if one person owns all areas early on. The failure mode isn't a small team, it's an unowned function. A few role archetypes show up again and again as these teams mature. Revenue integrity pharmacist or analyst, usually a pharmacist or pharmacy technician with strong EHR and CDM knowledge. This role bridges clinical accuracy and system build. An EHR analyst, a dedicated analyst with deep knowledge of the EHR. I was trained with Epic, so that means Epic Willow, Beacon, Resolute, Charge Router, and other charging workflows. This is one of the highest value partners a pharmacy revenue cycle team can have. This role can build charging logic, edit claim rules, create work queues, implement new reimbursement requirements, and deploy corrections in real time as issues are identified. Instead of discovering a problem, waiting weeks or months for an IT request to be prioritized, organizations with dedicated analyst support can test, validate, and implement fixes immediately, reducing revenue leakage and preventing future claim errors. Prior authorization technicians or coordinators. This role is a high-volume, process-driven role. Pharmacy technicians with strong payer policy knowledge often excel here. Denials and appeals specialist. This can come from coding or a pharmacy technician background. The best ones combine clinical documentation literacy with genuine persistence. Pharmacy finance analyst. usually a finance or accounting background layered with enough pharmacy exposure to understand drug level margin and reimbursement mechanisms. 340B and purchasing analysts should have deep knowledge of covered entity compliance, split billing software, and wholesaler contract terms. Revenue cycle leader provides strategic oversight for the program, establishes priorities, owns KPIs, and executive reporting. This person leads the governance and serves as the liaison between pharmacy, finance, revenue cycle, IT, and executive leadership. Pharmacists are not automatically the right hire for every one of these roles. Some of the highest performing people I've worked with in prior authorization and revenue integrity came from a pharmacy technician background. However, if you choose to hire outside of pharmacy, the person must have strong pharmacy knowledge. Match the role to the actual skills required, not a license. It's helpful if you have a team of technicians to have a dedicated pharmacist resource for oversight. Very few organizations get to hire a full team on day one. Sequencing matters. Stage 1, the generalist. One person, often a pharmacist, covers revenue integrity and denials informally, usually as a side responsibility to another role. This stage catches the obvious problems, but nothing systematic. Stage 2, the first dedicated hire. Usually this goes to whichever function is bleeding the most revenue. For organizations, that is either prior authorizations because of denials volumes or revenue integrity because of charge capture gaps. Pick based on data, not instinct. Stage 3, functional specialization. As volumes grow, roles split by function. This is where formal work queues start to matter because a specialized team needs a structured way to route work. Stage 4, program maturity. A manager or director layer forms. KPIs are formalized and the team starts operating proactively instead of reactively, forecasting the impact of upcoming CMS changes instead of just responding to them after the fact. So, where should this team report? This is one of the most contentious questions I get. And there's no universally right answer, but there are real trade-offs. Reporting into pharmacy keeps the team close to clinical workflows and drug knowledge, but can create tension if pharmacy operational priorities compete with revenue cycle priorities for time and attention. Reporting into hospital finance or revenue cycle gives the team more leverage with payer contracting and broader revenue cycle systems. But this risks losing the clinical fluency. It also loses the ability for the pharmacy revenue cycle team to influence operational changes that are needed to influence billing. A hybrid or dotted line structure reporting operationally to pharmacy and functionally to finance is increasingly common in larger systems, and in my experience tends to produce the best outcomes. However, this requires real partnership between both leaders of pharmacy and finance in order to work. Regardless of where the team sits, its success depends on strong partnerships with pharmacy operations, managed care, finance, revenue integrity, patient financial services, compliance, coding, and IT. No pharmacy revenue cycle team succeeds in isolation. Common mistakes when building these teams tend to be that hiring is for licensure instead of skill set. A pharmacist isn't automatically better at prior authorizations than a well-trained technician. Skill and temperament matters more than credentials for most of these roles. Mistake number 2, building specialization before you have the volume to justify it. A team of 5 hyper-specialized roles handling the workload of 2 people creates bottlenecks, not efficiencies. Mistake number 3, no shared visibility across functions. If your denial specialist and your revenue integrity analyst aren't looking at the same data, you'll fix the same root cause twice, once reactively and once too late. Mistake number 4, creating the team as purely a cost center. The teams that get sustained investment are ones that can clearly show that they recover and protect in dollar terms, not just what they process. Mistake number 5, treating the EHR team as a separate department instead of part of the solution. Revenue cycle issues are often identified by operational teams but solved through EHR build. Organizations that involve their EHR analyst early can implement charging updates, work queues, claim edits, and reimbursement changes in days instead of waiting months for an IT backlog to clear. Signs that you need to hire your next person. Your aging denials queue is climbing month over month, and it's not a temporary spike in volume, it's sustained trends. That points towards denials management, and you need to grow your team there. Prior authorization turnaround time is slipping past your internal targets, and urgent starts are being delayed waiting on paperwork. That points that you need to grow your prior authorization side. Charge review work queues are building up faster than they are being cleared, and new drugs launching faster than your CDM team can build and validate them. That points towards revenue integrity. No one on the team can answer a margin question about a specific drug or site of care without pulling data manually for days. That points towards growing your team in pharmacy finance. Hire against a trend, not a bad week or poor progress. A single rough month doesn't justify a new headcount. A steady 3 to 6 month trend in the same direction with cleaned up processes usually does. Building a pharmacy revenue cycle team isn't about copying another organization's org chart. It's about mapping your actual functions, matching the right skill set to each one, and sequencing the build so that specialization follows real volume, not ambition. A mature pharmacy revenue cycle team isn't measured by the number of claims it touches. It's measured by fewer denials, faster implementation of reimbursement changes, cleaner charge capture, stronger margins, and fewer surprises when finance closes the month. Get that right, and the pharmacy revenue cycle team becomes a strategic advantage instead of a constant source of fire drills. Get it wrong, and revenue leakage, denials, and operational frustration becomes the norm. Thank you for listening to another episode of Revenue RX. If you enjoyed today's episode, share it with a colleague in pharmacy, finance, revenue integrity, reimbursement, or medication access. And remember, healing patients is the mission, protecting the margin is the strategy. This is Revenue RX. Quick disclaimer, this podcast is for informational and educational purposes only. The views shared are my own and do not represent any organization I am affiliated with. This is not legal, financial, or reimbursement advice, and you should consult your internal experts before making any decisions.